Welcome to the Pharmacology of Ephedrine, as presented by the U.S. Army Graduate Program of Anesthesia Nursing, also known as USAG-PAN. The generic name for the drug we will be covering is ephedrine sulfate. It normally comes in a 50 mg per milliliter in water for injection vial. It will be drawn up in a 10 milliliter syringe with 9 milliliters of normal saline to make a final concentration of 5 mg per milliliter for the top of your anesthesia cart. As you can see, ephedrine may come in many different vials. Ephedrine is also available as a 25 mg tablet, but is not commonly used in anesthesia. Adrenergic receptors are transmembrane receptors that are coupled to an intracellular G protein. These G proteins have three subunits, an alpha, beta, and gamma subunit. These protein receptors are termed G-coupled protein receptors. The sympathetic nervous system's effects are mediated via two types of G-coupled protein receptors, alpha and beta receptors. These two classes are further broken down into alpha-1 and alpha-2, and beta-1 and beta-2. G-coupled protein receptors do not cause intracellular events by themselves, but are linked to intracellular primary messengers, which lead to a cascade of events and production of second messengers. Alpha-1 receptors are linked to the primary messenger phospholipase C, a transmembrane enzyme. G-coupled protein receptors that are linked to this enzyme are termed GQ-coupled protein receptors. Ligand binding to a GQ-coupled protein receptor activates the intracellular G protein. The alpha subunit dissociates from the beta and GABA subunits and activates phospholipase C. Phospholipase C is an enzyme that cleaves a membrane phospholipid into two molecules known as IP3 and DAG. IP3 acts on the sarcoplasmic reticulum and causes the release of stored calcium into the intracellular space. DAG activates the protein kinase C, which will phosphorylate many intracellular processes. In vascular smooth muscle, alpha-1 causes the release of intracellular calcium. When calcium is released, it binds to intracellular protein calmodulin, which forms the calcium calmodulin complex. This complex then activates myosin light chain kinase, which phosphorylates myosin and enables its interaction with actin, stimulating vascular smooth muscle contraction and raising blood pressure, as seen in this video. Ephedrine is a mixed-acting alpha and beta receptor agonist. Ephedrine may activate the G-coupled protein alpha-1 and alpha-2, beta-1, and beta-2 receptors throughout the body. Although it is able to do this directly, it is thought that the indirect activation through the release of norepinephrine is more potent than the direct stimulation. In contrast to alpha-1, alpha-2 is coupled to a GI protein. This will generally hyperpolarize the cell, making it more difficult to fire. Beta-1 and beta-2 receptors are always linked with adenylate cyclase, a primary intracellular messenger. G-coupled protein receptors that are linked to adenylate cyclase are termed GS protein-coupled receptors. Binding of ligand to a GS transmembrane receptor activates the intracellular G protein. The alpha subunit dissociates from the beta and GABA subunit and activates the intracellular enzyme adenylate cyclase. Adenylate cyclase facilitates the conversion of adenosine triphosphate, ATP, into cyclic adenosine monophosphate, CAMP. CAMP acts as a second messenger to disinhibit protein kinase A, pKa, which activates intracellular process through phosphorylation. Beta-1 activation in the heart causes pKa phosphorylate ion to phosphorylate ion channels and speeds up depolarization and repolarization of the heart, increasing contractility and cardiac output. Beta-2 activation on the respiratory and vascular smooth muscle stimulates the activation of PKA. PKA inhibits smooth muscle contraction by phosphorylating myosin light chain kinase and inhibiting its ability to activate myosin. Ephedrine's activation of beta-2 receptors will cause bronchial dilation and vascular smooth muscle dilation. The dosing of ephedrine in adults via the IV is 5 to 10 milligrams every 5 to 10 minutes. IM sub-Q in the adult is 25 to 50 milligrams, with a max of 150 milligrams in a 24-hour period for either IV, IM, or sub-Q. In children, their IM sub-Q recommended dose is 0.2 to 0.3 milligrams per kilogram every 4 to 6 hours. The onset and peak of ephedrine is different based on the route of administration. The onset for IV is 30 to 60 seconds, with a peak at 2 to 5 minutes. IM and sub-Q has an onset of 5 to 10 minutes, with a peak of 10 to 20 minutes for IM, and greater than 20 minutes for sub-Q. When given via the PO route, the onset is 15 to 60 minutes, with a peak at 15 to 60 minutes as well. Remember, PO is not commonly used in anesthesia. The duration of action for ephedrine, or TAF-alpha, is 10 to 60 minutes. The TAF-beta, the time it takes the body to metabolize 50% of the drug, is 3 to 6 hours. The main excretory mechanism for ephedrine is the kidneys in the form of urine, and carries 60 to 70% of the drug unchanged within 24 hours. There is minimal hepatic metabolism, which produces p-hydroxyephedrine, p-hydroxynorepinephrine, and norepinephrine. There are two anesthetic indications for ephedrine. The primary anesthetic indication for the use of ephedrine is hypotension induced by anesthesia. It is very useful in hypertension caused by regional or neuraxial anesthesia. Ephedrine is a good choice when you want to give a lighter version of epinephrine. It is longer lasting, but does not have the potency of epinephrine. The second anesthetic indication for ephedrine is post-operative nausea and vomiting, also known as PONV. For this indication, a 0.5 milligram per kilogram intramuscular dose is given at the end of surgery. The mechanism of action for this is unknown. There are a number of anesthetic concerns when giving ephedrine. We must be careful not to exacerbate any problems from cardiovascular disease, such as coronary artery disease, arrhythmias, or hypertension. Be careful when giving it to a patient with diabetes mellitus, as ephedrine is a potent vasoconstrictor and will decrease blood flow to the kidneys, thereby decreasing urine production. Although halothane is no longer used within the United States, it is important to note that administration of ephedrine to patients receiving anesthesia with cyclopropane or halogenated hydrocarbons such as halothane, which sensitize the myocardium, may induce cardiac arrhythmias. If a patient has taken an MAO inhibitor within the last 14 days before the start of your anesthetic, a hypertensive crisis may result if ephedrine is given. The primary references for this presentation were Evert's Anesthetic Pharmacology, Katzung Basic and Clinical Pharmacology, Goodman and Gildman's Manual of Pharmacology and Therapeutics, as well as the USAG-PAN drug book. This is a list of links to references that I also used. They are articles found within the web that have more current information than some of the books that were listed.